Hello viewers, I am Dr. Nadeem Rehman. Today I'm going to start a series of lectures about cardiac pacing and pacemakers and other implantable electronic devices. So today I have decided I'll give an overview, I'll give just a bird's eye view about the concept of cardiac pacing. As we all know, our heart, structurally speaking, it has three basic components: the muscle, the cardiac muscle, the vessels, and the conduction system. The conduction system is the basic electrical circuitry of the heart. As we know that the conduction system of the heart comprises of the sinus node, the AV node, the His bundle, and the Purkinje fibers. There is a concept that's called normal sinus rhythm. Normal sinus rhythm means the normal cardiac impulse originates in most of the people in the sinus node, which is an automatic tissue located at the junction of the superior vena cava and the right atrium. The impulse originates in the sinus node, travels down the atrial myocardium towards the AV node, then to the His bundle, finally to through Purkinje fibers to the ventricular myocardium, and ultimately results in depolarization and subsequently cardiac contraction. So there is also concept of internodal pathways between the sinus node, and we have got a sinus node and AV node, the internodal tracts. There is some controversy surrounding that concept, but we should also remember we have got three tracts: anterior internodal tract, middle internodal tract, and posterior internodal tract. So, normal sinus rhythm means the heart beats at a rate of 60 to 100 beats per minute. The impulse originates in the sinus node, travels down the pathway, as I already mentioned, and then subsequently on the ECG, when we locate the P waves, we will have positive P waves in the inferior, second, third, and AVF leads. So, this is something called normal sinus rhythm. So, when we talk about the concept of pacing, normally our heart is paced by sinus node. So there are other latent and subsidiary pacemakers also which have got their own pacing capacity. But in usual circumstances, the sinus node is the dominant pacemaker and takes over all other subsidiary or latent pacemakers, whether they are in the muscle, they are in the AV node, or they are in the ventricle. The dominant pacemaker is the sinus node. So whenever there is conduction system dysfunction, we, like in the form of sinus nodal degeneration or in the form of AV nodal conduction disease, the normal pacing system of the heart is disrupted, and there is a need for external pacing. So, what are the devices? We usually say that they're the implantable devices. There is a term called CIED, cardiac implantable electronic device. So CIEDs, we classify CIEDs into cardiac pacemakers, we ICDs, implantable cardioverter devices, CRT, cardiac resynchronization therapy, or biventricular pacing we call it, which can be subsequently divided into CRTD or CRTP. Then we have got ILRs, implantable loop recorders. Then we have got ICMs, implantable cardiac monitors. So broadly speaking, there are five categories of CIEDs. So in the subsequent lectures, we will discuss each of them by detail. So in this lecture, a broad overview about cardiac pacemakers. Cardiac pacemakers, as we say, so what are the indications of cardiac pacemakers? Whenever the normal conduction is disrupted, suppose there is a diseased sinus node or there is a diseased AV nodal tissue, so pacing is needed. So what are the indications? Indications, as we said, according to guidelines, this is we have class 1, class 2 indications, which we will discuss separately in detail. So we have got whenever there is a symptomatic sinus bradycardia, sinus node dysfunction, high degree AV block, alternating bundle branch block, bifascicular with trifascicular disease, or carotid sinus hypersensitivity result with symptoms. So anything complete heart block to high grade AV block with symptoms, chronotropic incompetence. So in those conditions, we need cardiac pacing. So we implant a pacemaker. As we say, cardiac pacemaker, the pacemaker, what are the components of a cardiac pacemaker? We say that the pacemaker usually we implant subcutaneously, or nowadays we subcutaneously in the right pectoral or the left pectoral region. There is also subcutaneous ICTs, or in children we can also implant in the submuscular tissue. So the pacemaker is a device which is implanted either in the right pectoral, uh, intraclavicular, lateral intraclavicular region, or left side. So what are the components of a pacemaker? Pacemaker has got a PG, what that's called the body of the pulse generator, the body of the pacemaker. That is a can which houses the battery, number one. Number two, it houses certain electrical circuitry in the form of a pacing circuit, in the form of an output circuit, the pacing circuit, output circuit, and sensing circuit, which we are going to discuss in subsequent lectures. So, pacemaker pulse generator is there. Pulse generator components, we have got a battery, which is usually lithium iodide battery, or then we have got electrical circuitry in the form of sensing circuit, output circuit, and pacing circuit. So then this body is connected to the heart either with a single lead or a double lead, depending on the indication. So that we have got leads. They can be atrial leads, or they can be ventricular leads, or in case of biventricular pacing, there can be an LV lead. Usually, there is a right ventricular lead and a right atrial lead. In case of biventricular pacing, there can be extra lead, that is an LV lead. So these leads, they have got insulations, and at the apex, they have got electrodes, usually a negative electrode cathode at the tip, and 1 centimeter proximal to that electrode we have got an anode in case of a bipolar lead, or a single electrode at the tip, that is cathode at the tip, and the can of the pacemaker serves as anode. This is called a unipolar pacemaker. So depending on the leads can be unipolar or bipolar, and subsequently these leads can be fixed to the heart actively or passively. So there are active fixation mechanisms and passive fixation mechanisms. So this is, grossly speaking, it is a device which is implanted in the left or right upper chest above the pectoral muscle. Then it is connected via leads to the heart. Those leads can be unipolar or bipolar, and the lead fixation mechanism can be active or passive. Usually, the ventricular lead is fixed to right ventricular apex, or it can be fixed in the septum also, that's called septal pacing, and the right atrial lead is implanted in the right atrial appendage. So this is the basic concept. So what does a pacemaker do? Basically, broadly speaking, it if there is a disease conduction system which does not, the normal conduction system does not depolarize the heart, so it has, our pacemaker serves the same function. So it depolarizes the heart whenever there is no intrinsic depolarization. Number one, it senses the intrinsic rhythm of the heart. Then it can also provide rate responsive pacing. What is the concept of rate responsive pacing? Rate responsive pacing means, because our body is not a stagnant or a static entity, our heart rate, our activity, metabolic demands, they keep on varying. So pacemaker can provide rate responsive pacing depending on the rate, depending on the metabolic demands, depending on our activity, depending on the sensors. There are various types of activity sensors also. Depending on that, it can provide pacing. So it has got a rate responsive pacing activity, it has got a depolarizing activity, it has got a sensing activity, then finally it has also got a storage activity. It can store the abnormal things that have happened. So this is the concept of pacemaker. So every pacemaker, there are various makes of the pacemaker. Various companies are providing pacemakers, and smaller devices are coming. So in case, then we have got modes of the pacemaker. What are the modes of the pacemaker? As I already told, we can have a single chamber pacemaker, we can have a dual chamber pacemaker. Single chamber pacemaker again can have an atrial lead pacemaker with a ventricular lead pacemaker. Whenever there is an isolated sinus nodal disease and we want to preserve AV synchrony, the coordination between the upper two chambers atria and lower two chambers ventricles, we usually prefer an atrial based pacemaker. Then we have got a ventricular lead when we do not prefer to preserve the AV synchrony and we believe that there is an AV nodal conduction disease, we provide ventricular lead single chamber pacemaker. So better is always a dual chamber pacemaker. So single chamber atrial and ventricular based pacemaker and dual chamber pacemakers. Then there are various modes. There's a NASP system which provides the modes to the pacemaker. NASP system which depends, there are five terms: chambers, chamber pace, chamber sense, what is the response to sensing, what is the rate modulation, and tachycardia function. So there is a usually four-letter term or a five-letter term assigned to a pacemaker depending on which chamber is sensed, which chamber is paced. So as I told you, there are three basic electrical uh, electrical elements in the body of the pacemaker. That's the output circuitry, there is a sensing circuitry, and there is a timing circuitry. So pacing, sensing, pacing, as we say, output, sensing circuitry, then we have a timing. What does timing circuitry means? Timing, what timings we program. Once we implant a pacemaker, we do programming at that time. So what are the timings we set? In the form of, like, what is the AV delay we set? What is the PVRP we set? This is the timing circuitry. Post-ventricular atrial refractory period, the timings we set, and at that time we check the PR. PR, what does PR means? We check what is the P wave we are getting at the time of implantation. Usually more than one is significant, or what is the R wave more than 5 millivolts is significant, we consider it as significant. Then we check various parameters, like we check thresholds, we check the impedance, we check threshold, we check impedance. Then we also check the sensing function. So today, as I have told you, it is a broad overview about the concept of pacing. So in a nutshell, whenever the intrinsic electrical circuitry of our heart becomes diseased and it results in abnormal rhythm in the form of bradycardia, very low heart rate, with subsequent symptoms in the form of low cerebral perfusion, fatigue, hypotension, dizziness, falls, syncope, loss of consciousness. So it merits cardiac pacing in the form of a pacemaker. I am hopeful that I am able to provide to you a basic overview of the concept of cardiac pacing. In the next set of lectures, I am planning to take each topic step by step so that we finish the whole concept of pacing, starting from the from the basics, from the nuts and bolts, to the more complex topics related to cardiac pacing. Thanks a lot.